So we'll save the questions until after Kirsten's presentation. And Kirsten Davidse is a nurse practitioner in endocrinology at the Erasmus University Medical Center in Rotterdam. She specializes in genetics and congenital endocrine disorders with a special interest in the transition from pediatric to adult care. Currently, she is the chair of the Dutch Society of Endocrinology Nurse Working Group, and she's also the chair of the European Society of Endocrinology Nurse Committee. So very welcome. And I'll just let you start your presentation.
So, good evening, everyone. And as mentioned by Maria, my name is Kirsten Davidse, and I work in the Erasmus Medical Center in Rotterdam, the Netherlands. And as a nurse practitioner, I am part of the Center for Adults with Rare Genetic Syndromes, together with these three other wonderful women. And even though osteoporosis is not a part of my main focus, I often encounter with this during my outpatient clinics. Because in the Center of Adults with Rare Genetic Syndromes, I take care of a lot of patients with various endocrine disorders like Klinefelter syndrome, Prader-Willi syndrome, Chart syndrome, and Kalman's syndrome. And there's one thing these syndromes have in common. They all have or have a high prevalence of hypogonadism. And hypogonadism in adults is a well-acknowledged cause of overall bone loss and a contributor to developmental of osteoporosis. And this is why I regularly have to take osteoporosis into encounter or the possibility to develop osteoporosis during my outpatient clinic. What we're talking about secondary osteoporosis, as mentioned by Professor Brandy as well, secondary causes for bone loss can involve underlying process and medical problems, as well as the use of certain medications that can either affect achieving peak bone mass as a young adult or result in excessive bone resorption, affecting the bone health and quality. And this means it can affect a lot of people of all kinds of ages. No matter your age, diagnosis of having osteoporosis and having an increased risk of a fracture can influence the quality of life. Skeletal conditions such as osteoporosis and related complications, for example, vertebral fractures, are considered having a negative impact on physical, mental, social, and emotional health, with consequences as deterioration of quality of life. Various studies have looked into the consequences of having osteoporosis on quality of life. And it's mentioned that having an increased risk of a frailty fracture is a main determinant of impairment on quality of life. Physical and social function are reduced, and loss of quality of life is more severe in patients after a hip or multiple vertebral fractures. And the longer after the fracture, the more of quality of life improves. However, quality of life is not completely restored. Patient-reported outcome measures, shortly PROMs, have been developed and are increasingly used in healthcare services to assess the impact of a disease, a treatment on health-related quality of life. Since areas of concern to specific patient populations may be overlooked with generic PROMs, disease-specific PROMs are developed to address those important aspects for patients with a particular disease, including osteoporosis. These are 9 examples of specific questionnaires related to osteoporosis and quality of life. The Quality of Life Questionnaire of the European Foundation for Osteoporosis is an osteoporosis-specific questionnaire, most commonly used in the literature and is considered a valid and reliable PROM for healthcare-related quality of life assessment in osteoporotic patients. The questionnaire contains 7 domains, namely the domain of pain, activities of daily living, jobs around the house, mobility, leisure and social activities, general health perception, and mental functioning. In every one of these 41 questions, the patient can choose one of the multiple choice answers. For example, how often have you had a back pain in the last week? Or do you have any problems with taking a bath or a shower? And the last example, how would you rate your overall quality of life during the last week? And this gives a good look into what the disease is doing with the patient itself and how maybe some deteriorations can be addressed. So actually, I'm working in the Netherlands, and in 2022, a new guideline was adopted in the Netherlands. And as mentioned before, being not a specialist in osteoporosis, this guideline provides me guidance. As a part of the 5 guidelines are made, showing what to do in which patient for diagnosis and treatment of osteoporosis. There's a flowchart. There are actually 5 flowcharts which can help you decide. There's a flowchart for treatment advice in patients on glucosteroids longer than 3 months, a flowchart for evaluation of a therapy-naive patient over 50 years with a recent fracture, one for evaluation of a therapy-naive patient without a recent fracture, however, with an increased risk profile, and there's evaluation on therapy, one for bisphosphonates and one for denosumab. And I actually wear these in my bag every day just to pull them out if necessary. But for you, I'm just gonna show you 2 of the flowcharts. This is the flowchart for evaluation of therapy-naive patients without a recent fracture, but with an increased profile. So you start at the top, calculate risk score, check clinical risk factors, and DEXA scan for baseline and therapy choice. And which way to go is dependent on the bone mineral density. Then you come across maybe a choice of age. However, on the bottom, there are some first and second choices given regarding therapy. This is the one for evaluation of therapy-naive patients after a recent fracture. And keep in mind, this is for patients above 50 years, which is mentioned in the first step of this flowchart. Together with having a certain type of fracture taking consideration. And again, at the bottom, more choices, first choice and other choices for treatment are provided. As seen in both flowcharts, there's a very important role for lifestyle and fall prevention advices, as well as considering suppletion by calcium and vitamin D in patients with or with an increased risk of osteoporosis. Equipping patients with proper knowledge to reduce their risk of developing osteoporosis or associated complications is crucial. I think nurses can play a very important role in assessing the patient's knowledge of osteoporosis, providing education. And this education should include information about healthy diet, weight-bearing activities, calcium, medication adherence, ambulatory aid for patients who have an unsteady gait, limited, and do not forget about smoke cessation, limited alcohol take. As I now made clear, what you can do as a nurse with for patients with osteoporosis, I wanted to show you how the nurse competency framework helps me to assess my current level of functioning and what I can do to enhance my development. The competency framework for adult endocrine nursing can help to deliver constant high standards of care, identify the level of practice, and plan a career in a more structured way by pinpointing personal education and developmental needs. This framework is available on the website of the Nurse Committee of the European Society of Endocrinology and is currently translated in 6 languages. So today is focusing on competency 9, osteoporosis. For the competency of framework and also for competency 9 on osteoporosis, the Bennett novice to expert concept has been used and adapted as the base for these competencies. An endocrine nurse is considered, is on an expert level, is considered to have some years of experience in the field and also working independently. So let's start with competences on the level of competence. And this is the start in providing nursing care for patients with osteoporosis. And as you can see, it contains mostly goals on developing sufficient knowledge to make steps towards skills. Let's put my situation among these competencies. So during this talk, I covered some of these competencies, and such as demonstrating an understanding of the mechanism of the disease processes, which may cause and contribute to osteoporosis, having knowledge and understanding of the national guidelines, knowing the appropriate treatment modalities, and able to explain. Although some of these competences are not covered during this talk, I consider myself to do so and apply these in my daily practice. According to this competency framework, I can call myself competent and grow on to the next level of proficient. So this is the next level. And again, I'm going to show you the same thing as I did with the previous level. Using this, but probably all kinds of competency frameworks, require being both critical and honest towards yourself and others. Sometimes it helps to look at the competencies together with a close colleague. For example, in my case, I did not consider myself a role model for junior staff. However, one of our physicians in training did consider me a role model to her regarding care for patients with secondary osteoporosis. Sometimes we tend to look too critical towards ourselves and miss out on some of the development we've already made. So let's peek at the expert level of this competency and identify where I can enhance my development as a professional practitioner. And I think you know the drill by now. So let's do it for the last and final time. As expected, I'm not an expert of this competency. However, it shows me immediately on which part I can enhance my personal growth. It gives me insight on where opportunities are and makes me think about what I can do to use these opportunities. And in the long end, with the ultimate goal to improve quality of care for patients. So again, the competency framework for the adult endocrine nursing is freely available on the website of the Nurse Committee of the ESE. And with this QR code, I hope it's feasible. I even made a more shortcut towards this website. And while you're on the website, take an opportunity to check out all the other things that were there. For example, previous ESE talks, nursing webinars, information about the nurse membership, but also information about nurse travel grants toward ECE 2025 will be announced on this website. For now, I'm moving forward to the end of this talk. I hope I have showed you that the competency framework can help you identify opportunities to grow as a personal professional. That looking beyond your main focus gives you an insight how you can grow on your side topics, because getting out of your comfort zone can also be an opportunity to grow. I would like to thank you all for joining. And if there are any question, I'm more than willing to answer these. Thank you.
Thank you, Kirsten, for this presentation. And we have a lot of time for questions and answers. Please use the box in the bottom part of the Zoom window. I'll start with the ones already there. And I will start with a question of my own for Professor Brandy. It's regarding what do you think about the future of finding patients before they get their fractures? Do you think, for example, artificial intelligence is a tool that will be helpful for general practitioners or other physicians?
Yeah, artificial intelligence obviously can help in this direction and will help in the future in areas where we know that we have a risk population, but that would be very easy at menopause now, because menopause is a well-recognized risk condition where we don't do very much. Women don't take estrogen therapy anymore. Gynecologists tend not to use osteoporotic drugs. And also the problem is reimbursement, because this is an area where certainly prevention costs much more. So it's an area where if you want to prevent, we have to invest some money, and the results will be seen in the long term. And this sometimes for the decisors is not what they want. They want quick results, and that is one of the reasons for which we've concentrated on fractured patients, because we know that there is a need. But we are moving backwards to the woman at menopause, that for us is an area of great interest, like all the secondary conditions of osteoporosis that I just mentioned, where the endocrinologist becomes central, because the endocrinologist is good at that. We are used to use markers because we measure hormones. We are used to think about metabolism overall. So endocrinologists are going to be central in the recognition of secondary osteoporosis in the future. But we can just to see what happens in the next few years for the attention that we are going to put back into the postmenopausal woman. We need to get back to the gynecologists, educating more the gynecologists to the developments in the area of therapy that they don't know as much, because they've been abandoning this area of the postmenopausal care. And so we need to get back there. And certainly taking an eye on education of doctors that cause osteoporosis, because there are doctors that for the cure that they do look at the oncologist, they cause osteoporosis and they don't do anything. So artificial intelligence can find a space with all the difficulties we see in the application of artificial intelligence because of the cost that artificial intelligence can have when you introduce artificial intelligence within the hospital. But besides, at least in areas that we recognize as critical, where nothing has been done. But that's a very good question. Prevention of the fast fracture should be our next aim.
Thank you. So I'll continue with some questions from the question and answer box. We have, sorry if I don't pronounce your name correct, but Shakel Abella, what CV risk score do you use in romosozumab, and what is your threshold in deciding as to whether or not to give it?
You see, the risk score usually that the doctors use is the one that is, we use FRAX score. So we use the FRAX card to evaluate. Now, for patients like the romosozumab treated patients, obviously the imminency of risk of fracture for us is very important, because if the patient has an imminent risk, romosozumab is the one that can prevent fracture within the 6 months of treatment. So for us, it's very important to recognize imminency and high risk, because otherwise our agency will never allow us to give this under reimbursement. So when we decide under two, we have to have a double vision. Is what we would like to do and what is allowed to do, because some of these drugs have a very high cost. If they are not reimbursed, they cannot be used in the general population because the patients should pay out of their own pockets.
Thank you. Next question is also to Professor Brandy. You said 5 year chance. You said 5 year cancer-free before starting TERI or abaloparatide. Please explain.
What? I didn't understand the question. I'm sorry. Before using...
Sorry. 5 year cancer-free before starting.
Yeah. I explained you clearly because these two drugs, the first one was teriparatide that was developed almost clinically almost 20 years ago. It's a very old drug. Then it came into the market 16 years ago. And in the that was developed by Eli Lilly, what happened was that the company used very high dosages of teriparatide for another scope in animals, very young animals, and they developed osteosarcoma. And we were at the 18 months of the treatment with teriparatide, and the company wanted to stop the development of the drug because, osteosarcoma is a bad tumor. The EMA at the time looked at the data and they said, no, we stopped the study. Instead of going into the 3 years development that is usually for the registration of these drugs, we stop at the 18 months, so 1 year and a half. And now we will sell the drug with a black box. And so the drug was sold around the world with a black box that is like the cigarette. This can damage your health. Besides that, the drug was sold around the world. And most of all, after 16 years of analysis of the population that has been treated, with millions of people treated around the world, 10 millions, 100 millions. So then no one has been developing osteosarcoma because the dosage that we use is very small, very little. And we knew also that even in conditions like hyperparathyroidism, long-lasting hyperparathyroidism, sometimes it happens, unfortunately, patients never develop osteosarcoma. So it was really the very high dosage given acutely to very young animals. Think that today, this type of peptides in certain parts of the world are given chronically to hypoparathyroid patients. So besides that, obviously, at that time, we were so afraid that we decided to put limitations. So if a patient has cancer with the potential of bone metastasis, we don't want to use that drug. All the cancer have the potential of bone metastasis. So we tend not to use that drug because we are fearing problems at the bone level. So if the patient was 5 years free of cancer, after the diagnosis of cancer, then you can use the drug. So I hope I answered the question.
Thank you. We have a follow-up question to not this one, but the last one. The one regarding what CV risk score you use in romosozumab and what, the last question. So the follow-up question is, thank you, but with the cardiovascular risk, what score do you use? Do you use Q risk 3?
That's a very good question because unfortunately, this was left to us. A regulatory agency decided that it's the clinician who has to evaluate the risk score for cardiovascular events in a patient. That's not really fair for the clinician because we can refer to the risk card that we have today for cardiovascular events. And those, for instance, for the very elderly people are not suitable because they are not valid for that population. So usually you have to use your common sense and some clinical knowledge that obviously you need to have. And, to do a very good evaluation, both in the family and personal history of the patient. I tend to do a lot of exams before giving that drug, not only an electrocardiogram. I do also test of evaluation of cardiac function, magnetic resonance for the brain. I'm very strict on that because for me, cardiovascular risk is important. And unfortunately, we treat the population that has the highest cardiovascular risk. So anything happens in a patient during the treatment, they're going to get back to you and asking, do you think that this is the problem related to the use of the drug? And no one of us can say, no, that's not related, because we cannot answer like that. So that's the reason for which I tend to be very selective at the beginning, making sure that that patient is really fine, cholesterol is under control, coagulation doesn't have problems. Otherwise, I opt for another treatment. Because if we put together an anti-resorptive, like denosumab, together with teriparatide, we get a good admixture even for the very severe patients. So that's the reason for which obviously romosozumab is a great drug, but we have to consider the limitation of cardiovascular risk as serious because we as prescribers are responsible for that. It was not given by the agency, the level, you know, it's not given by the agencies. They tell you, you have to evaluate the risk. And so it's the doctor that does that. There are people that feel very comfortable. They don't care. They say, oh, no, but there is no risk because also the results obtained within the controlled clinical trial had some problems because we were confronting romosozumab with alendronate that we know today preventing cardiovascular risk. So if you compare something that does nothing with something that prevents, eventually you become the one that is not favored. So even in the design of the study was not perfect in this sense, but still the data are there. The agencies have been pronouncing themselves, and we are left with the boiling potato. So I hope I answered the question. Be careful.
Thank you. Next question is, if breast cancer patient is on tamoxifen, does it help improve the bone, or isn't it enough to protect patient?
You know, for many years, because tamoxifen is a certain molecule. It's like raloxifene, but was developed for metastasis of mammary cancer because it acts as an anti-proliferative. So that is the point for which tamoxifen was developed. Raloxifene is inert at the breast level, but it acts as a bone metabolic factor in bone, mimicking the effect of estrogen. So that's for this reason they're called selective estrogen receptor modulators because they are selective by tissue. Now, tamoxifen, we knew that was not acting as a pro-resorptive. It's an anti-resorptive like a 17-beta estradiol. And if you use only tamoxifen without aromatase inhibitors, because sometimes they associate the two therapies, I've seen in protocols where they give tamoxifen and aromatase inhibitors together. In that case, with tamoxifen could protect bone, you know, because it acts on bone as an estrogen. It depends the levels of osteoporosis you start with, because also 17-beta estradiol shouldn't be given to patients that have a severe osteoporosis. I would opt for another molecule, not 17-beta estradiol, because it doesn't have that power. 17-beta estradiol, like raloxifene and eventually tamoxifen, should be used closer to menopause when the levels of bone density is not so low, because their power is lower. You know, and so that's the reason for which, you know, there is not an answer that is universal. It depends on the patient. I had a patient that was treated with aromatase inhibitors and tamoxifen together. In that case, I gave also denosumab because I can rely that tamoxifen by itself can be acting against the negative effect on bone resorption that aromatase inhibitors exert in the bone tissue. And that is the case where bone metabolism can get help to you, because if you analyze then the bone metabolic markers, you can find that resorption is high. And so if it's high, I have to do something. So that's the reason for which the metabolism of bone should be always taken into consideration when you want to be a good doctor of bone.
Thank you. Next question. If a 55-year-old female has T-score minus 2.6 lumbar spine and 0.9 femoral neck, no risk factor or OP, will you start osteoporosis medication like denosumab?
I will tend to exclude risk factors. For instance, I can have this wonderful postmenopausal woman that is low in weight, doesn't drink milk, doesn't eat any type of cheese. The intake of calcium is very low, vitamin D is low, no physical activity. So in that case, I tend to correct the style of life. And I will see that patient 1 year later. 1 year later, nothing happens in that lady if there were not previous fractures, obviously, because if there was a fragility fracture, like she tells me that 2 years before she dropped on the floor and she broke the wrist. In that case, for me, I consider that patient a risk period. Obviously, I start the treatment. But in the case of someone who is really the negative behavior for bone, and now I can change something close to menopause, I can wait 1 year, changing lifestyle and to see what happens. Also because remember that the risk of fracture is linked to age, and age is an independent risk fracture. Now, if I have -3 at 50, my risk is lower than if I have -3 at 70 or 80. So if close to menopause, I can wait without major problems, unless I have the special patient. I tend to be very personal. I personalize the therapy in osteoporosis. There is never an answer that is the way, because we are prescribing chronic therapies. And we know that the enemy of osteoporosis is that the compliance is low. So we need to study very well what we prescribe in order to get results. And so the person is going to continue the therapy and to not make errors in terms of side effects, not evaluated well, and blah, blah, blah. So it's very important for us to personalize the therapy. There is not an answer that is yes or not, okay? It's changing depending on the patient.
Thank you. Next question is for Kirsten. Are these resources, Kirsten, are these resources you find most effective for teaching patient refracture risk?
Yeah. So I think the question is are there specific resources who I think are most effective for teaching patients? So as I mentioned during my talk, I'm actually really not an expert on osteoporosis. However, I see, and I have to take this disease in account with a large group of my patients, which is also a patient population with various level of understanding. So I do not have one specific resource on how to teach patients. I have made my own resources in the last couple of years just to explain how to guide them. And most of all, it starts with patient education and explain them why they have to take their medicine, what is doing this estrogen or testosterone on their bones, and what's important to do and why you have to do this. And you have to adjust this to every patient regarding their level of what they can understand.
Thank you. And next question. Thank you so much for this interesting topic. How can we prevent this better before actually patient develop fracture? Is there an algorithm to see which patient will qualify for DEXA scan? I mean early identification rather than treatment after it happens.
Who would you like to answer the question, Maria?
Sure. First of all, I believe that we need to tell the people, everyone, that primary prevention is very important. It's not just, I do some primary prevention. Primary prevention should continue also when we prescribe the drug. It's not that the drug cancels primary prevention. Primary prevention for us is the right intake of calcium. Remember, calcium is an element that we take from outside. It controls our brain and it controls our beating of the heart. If our calcium is low, everything is accommodated within the endocrine system to take the calcium from urines, to take the calcium from bone, and to activate the metabolism of vitamin D in order to absorb more calcium from the gut. Now, that tells us that if I don't ingest foods that are good for my bone allowance, that is a daily allowance, not a weekly allowance, my bone is going to be destroyed in time because I take the calcium from bone. So we have to stop that trend because it's like having an account in the bank and every day you take a lot. At a certain point, you will not have anything more. So you will be just bankrupt. Now, in order to not go into bankruptcy, you need to acquire the calcium from the outside. And that is first line of primary prevention. Intake of calcium in the right quantity since your birth, I would say, since you are in uterus because your mother has to think about you. But at that time, the fetus is pretty smart, so he takes everything he needs because he wants to mineralize his own bone. But when you are born, someone has to take care about the calcium intake. So, and then when you are growing up, someone has to take care about your calcium intake. When you are a healthy adult, someone has to take care about your calcium intake. When you are an old person, someone has to take care about the calcium intake. So that's the reason for which primary prevention is important. The second point that we recommend is to maintain a good synthesis of vitamin D at the skin level, because our skin synthesizes the pro-hormone. Now, in order to synthesize the pro-hormone, we need to be exposed to UV light half an hour a day, arms, legs, neck, and head. That is going to be difficult during the winter. So let's put in mind that during the winter, we go into hypovitaminosis D, every one of us. Today, I had 2 children of a patient that were doing a special test because of a disease that the mother was affected for. And both of them were highly and severely hypovitamin D. So they were on their 30s. So that means that we have to expose ourselves to the sunlight for a short time during the day, but every day. Otherwise, we don't synthesize vitamin D. After menopause in the elderly, our skin gets old and does not make this synthesis anymore in the proper manner. So then we need to take supplementation of vitamin D. The third point of prevention, that is primary prevention, is moving, doing physical activity. I would say every day doing something, trying to do something. But a lot of people today sit down like us today. Let's say that you are working in a company and you are working at home. Today, from 9 a.m. to 7 p.m., you were sitting in front of a table trying to do your job. But at the table, doing nothing. You cannot do physical activity when you are lecturing or listening. So you are sitting. So physical activity. And this is what we recommend in primary prevention. And we recommend this to any person of any age when they get to ask for suggestions. So primary prevention for us is very important. It can become actually transforming also the life of a person that was at risk now in a lower risk. So, but it's not everything. For patients that are already severe, we cannot use only primary prevention because we know that it doesn't work.
Thank you. So next question is, can you explain the treatment of osteoporosis during pregnancy and lactation? What about breastfeeding?
As I said, I'm following over 300 women who fractured during pregnancy or after delivery. So I have a large experience as doctor in this population. And for many years, we were there trying to watch these women and say, what do we do? How do we have to do? At a certain point, I decided to do. Because if you are very fragile, you need to be put in prevention of anything that can break your bones. For instance, for the elderly population, we say, don't drop too much on the ground. Falls are a risk for you, and you have to prevent falls. For a woman at pregnancy, the problem is not the falls, because she's still young enough not to fall around in any moment. But delivery is a very critical moment, because in the delivery, the pressure that you put on the spine is exceptional. No 1 kilo, 2 kilos, 100 kilos, just the pressure. So many women fractured during delivery because they were fragile and no one recognized fragility. So delivery is better C-section. And that is what, in this case, we recommend C-section. For instead, for the patients that are breastfeeding, we know that during breastfeeding we lose bone, and so obviously we say shortening the time. I had many patients who had the second child after the first delivery and with fractures, and the second pregnancy they never fractured. So if a person fractures during pregnancy, the first pregnancy, and the second doesn't fracture because she knows now what she has not to do, we know that we can prevent the fractures. Ideally, we should introduce in the first trimester a card risk that reads which one could be your risk of fracturing. For instance, a woman that is young, she had anorexia nervosa and months of or years of amenorrhea. This person also doesn't eat very well. So milk derivatives, they are too bad. I cannot have those. This person also tend to be, should be treated eventually with corticosteroids because of some problem that she's going to suffer. This person already fractured. Now, this is a person that is at high risk. So we need to capture that risk in the first trimester in order to make all the suggestions, for instance, accommodating calcium, vitamin D if necessary, and having this person get into pregnancy with the least risk, recommending because of the fragility, not to drop on the ground, avoiding any dangerous type of activity, and not lifting too much weight, this kind of recommendations. We cannot treat during pregnancy, and we cannot treat during lactation. We should just start the treatment after pregnancy and lactation. Usually, bone-forming agents are good. Many of these women suffer because they have a low bone formation. And we have seen that teriparatide is a good drug. Otherwise, if the patient exceptionally shows up after stopping lactation, a very high bone turnover, you can use also bisphosphonates. They are not indicated for this population because all the drugs were developed for postmenopausal women. And you know very well that for pregnancy, nothing is going to be recommended because there are no studies. So we use these drugs because we know that we can help, we can have a good response in terms of bone density. And then if the woman wants to go in a second pregnancy, we don't want to start with -3 or -4 at the spine and getting into the second pregnancy, because that could be a kind of risky.
Thank you. And next question is from Miriam Asia. It's thank you, Kirsten. Can you possibly give specific examples on how to achieve these competencies at each level?
Sure. So as I was showing you guys the competency framework with all its competencies within it, of course, when you, for example, monitoring results or advising on treatment changes, one time you're not considered competent. So you should consider, or you should make like a document where you can keep track of all the things you're doing according to the competency framework, collect evidence which can show you're competent on this framework, on this competence, not one, but multiple times. So for example, you can make like a document focusing on one of the competence. For example, discuss with patients the advantage and possible disadvantages of treatment, and it gather evidence by asking a colleague to join you during your outpatient clinic and hear you out how you're discussing this topic with your patient on that day, and gather enough evidence to prove you're competent and can move on to the next level. I hope this is a little bit what Miriam was looking for in her question. But I think you should, collect evidence on the various competence.
Thank you. And next one is, in pediatric endocrinology, are patients treated with medications to suppress puberty at higher risk for osteoporosis? What is the guidance which we should provide to these patients?
Now, for children, obviously, we can use even osteoporosis drug. It happens in some rare disorders, look, osteogenesis imperfecta. We use drugs for osteoporosis, even in children. Exceptionally, we use drugs, obviously, to give answers. They are out of indication. Now, in these cases, you have to follow them closely. For instance, these days in Italy, we have this ultrasound called REMS, where we can measure the spine and the hip, even in children, so there is not radiation, and then you can monitor their changes. It happens also for children that have cancer, leukemia. So following them throughout the disease, let's say every 3 months, you can make a REMS evaluation, and you see the abdominal density is going down. In that case, you can decide what to do. Eventually, if the bone biomarkers show or a decrease of bone formation or an increase in bone resorption, you can decide what to do. You know, children are unfortunately an area where the decision is left to doctors. And you have to decide case by case. Sometimes you can be a decision that can be dramatic, but can be very helpful for the child. We tend to be careful in what we do, but if there is the need, we use drugs, yes. Otherwise, we make sure that, for instance, calcium is offered, vitamin D is okay, and what is possible is to do activities and physical activities. So implement the primary prevention is important, not just to forget, because that is the kind of inheritance that you will have for the future, because that's the time which you start to develop your peak bone mass that you are going to reach around the 25 years of age. So if you lose years that are so precious for the reaching of the peak bone mass, then you will be someone who will start with a lower bank account.
Thank you.
This decision, just to tell the audience, this decision needs to be taken with knowledge. So if you are a person that knows exactly well what you should do, mostly in cases that are so difficult, like the ones you are mentioning, then you can take decision with knowledge and for the good of the patient. So I usually tend to treat children like I would treat my grandchild. So what I would do for my grandchild if it was in the same situation, I would do this, then I can do also on the others.
Thank you. We have a few more questions at the moment. So the next one is, does high bone tumor marker guide your choice of osteoporosis medications? If resorption markers high or formation were high, how to select and then monitor?
No, tell me again, I'm sorry. So if...
Sorry. Does high bone turnover marker guide your choice of osteoporosis medication?
Yes, it does. For me, it does. Obviously, again, if I have a person, for instance, that is under treatment with corticosteroids, very often bone formation is low. That patient would take more advantage at the moment in which bone formation is low, and also bone resorption is low in that case, because the system is coupled, of an anabolic that eventually could be used for a while, 6 months, 1 year, and they can switch to an anti-resorptive. So not giving, for instance, to a patient that is very, very low turnover, a drug that is decreasing even more the turnover, that is the potent anti-resorptives. So I tend to use, if it's for a while, in anabolic. So for me, it's very important. Unfortunately, very often these patients shouldn't be treated reimbursed. In that case, they will have to pay for that. In certain special cases, to have the patients paying for the drug, because the drug is too important that the treatment becomes of great relevance.
Thank you. If a patient is on denosumab and decide to stop, which osteoporosis medication to give and for how long to continue? And can we stop the new medication then?
If a patient is treated with denosumab, the question was on denosumab?
Yes, yes, that's correct.
Okay, if the patient is treated with denosumab, in that case, I cannot stop the therapy when I like, because there is a rebound effect that is very well known. Besides, this rebound effect has been always presented as a terrorism. We are not to be terroristic, because if I take an antihypertensive and I stop the therapy, my pressure goes up even more than before. If I take an anti-diabetic and now stop the therapy, my glycemia is increasing even more than before. Rebound effects is very well known in medicine. Is that because we know this, we recommend the patients not to stop the therapy by themselves. That is the case in which compliance is high, in fact, because they know that they cannot stop. But if they want to stop, they have to tell us, and we will drive them to a therapy, for instance, with potent intravenous bisphosphonates, like zoledronate. And the patients are treated with injection. We follow them in 6 months' time, at least is what we do. If the bone resorption starts to be high, we give a second injection, like we do in Paget disease of bone. And this usually resolves the problem. I tend not to use oral bisphosphonates in this case, because I need a power that is stronger, and intravenous bisphosphonates are a way of avoiding problems in these patients, but recommending them not to stop the therapy since the very beginning. A good informed patient usually is a good doctor of himself. So if you give all the information that are needed, they will not do things wrong. You need time to talk with the patients, yes.
So we have one final question. I think we don't have enough time for any other questions. So for how long the IV solandronate, please, after the denosumab?
You know, I stopped the denosumab because I tend not to stop at 10 years. I don't follow those recommendations. The drug was studied for 10 years. This doesn't mean that I use a drug for 10 years. I use in my life eventually an antihypertensive all my life, and that was studied for 6 months most, or at most 1 year. And I don't ask myself, how long I have to use this drug? So the recommendation used for 10 years doesn't make any sense. That needs to be corrected, actually. But besides that, when I stop denosumab, usually is when the patients get too high bone mass. I had patients that got to +1, +2. So for me, it's too high. And then in that case, I stop and I give solandronate. And for me, it's good enough. Up to now, the patients that I stopped, they were enough, it was enough 1 injection, but 2 injections were perfect. So 1 every 6 months. That is a posology that we use also in Paget's disease of bone. So it's not something just out of mind.
So thank you so very much, Professor Brandi. It's been very interesting, and I've learned so much. And thank you, Kirsten Davidse, for your excellent presentation, and for all the participations with excellent questions and difficult questions. So I would like to just sum things up with a few more short slides. Just to get you to remember upcoming nurse webinars from ESE talk. And also remember to stay to date with the membership of European Society of Endocrinology, and remember how much it gives us as nurses to be members. Check the website for membership fees. And I hope to meet you in Copenhagen in the spring for the joint meeting with ESE. So thank you. It's been a pleasure.
Thanks. See you soon at the ESE meeting. Bye.
Bye.